So good afternoon. My name is Darius Quinn. I'm one of your human resources managers with the HR department. Would like to welcome you to today's webinar that is focused on providing you with the facts about the COVID-19 vaccinations. We've assembled kind of an all-star panel here to help bring you once again the facts and the latest information regarding the COVID-19 vaccinations. And really the hope behind this is that you will be able to share with other friends, colleagues, and family members, again, fact-based information about the vaccines in an effort to help those folks to make wiser decisions. So I'd like to go ahead and turn it over to Dr. Nirali Bora, who is the medical director for the Kent County Health Department. Her and I had some discussion about how can we provide employees with more information. Folks are still hesitant. And I trust Dr. Bora. In fact, I trust her with information and in helping make decisions, even for my own family. So we wanted to, again, bring fact-based information to you. So Dr. Bora, we thank you and the team here. And if you wouldn't mind just taking it, and we'll move through introductions and get through our information this morning.
Sure. Thank you, Darius. Thank you for having us here today. And thank you all for joining us during your lunch hour. This precious time, and that you chose to spend it with us. So we really appreciate that. So like Darius said, my name is Nirali Bora. I'm a family physician. I've been at the health department for a few years. And it is really my pleasure to have this group of people here to work with us together to answer some questions that you may have had about the vaccine. So with that, I'd like to have Dr. Black, do you want to go ahead and introduce yourself?
Hello, everyone. I'm Dr. Carla Black. I'm the Emergency Preparedness Coordinator at the Kent County Health Department. And the reason why I'm here today is because my previous life, before I got into emergency preparedness, I actually researched viruses. And so that's what my PhD is in. So that's me.
Thank you, Carla. Dr. Sullivan?
Yeah, hi, I'm Dr. Liam Sullivan. I'm one of the adult infectious disease physicians at Spectrum Health. And I'm here today because I've been one of the lead physicians working a lot with the vaccination rollout at Spectrum Health and helping to provide education to our employees as well as the community as much as possible. Pleasure to be here.
Thank you. And Takia?
Hello, everyone. My name is Takia Rickenstrick. I'm a physician assistant here at the health department, and I'm here because initially I was very concerned about getting the vaccine. I had just had a baby, and there was no studies on or guidance on whether or not I should get the vaccine with breastfeeding. Ultimately, I decided to get the vaccine, and I want to be available for those who have similar concerns and just answer questions if it'll help.
Takia is also a trusted medical provider in our health department, so we're really happy to have her expertise here as well. So we're going to do about 30 minutes of a presentation and really want to leave most of the time for questions that you have. We'll start out with Dr. Black, and then Dr. Sullivan and I will present for about 10 minutes each, and then we'll have time for questions. So go ahead, Dr. Black.
Couldn't get off mute. This is starting off great. Okay, hello everyone yet again. So today I'm here to give you a bit of a science lesson. We're going to talk about the science of how mRNA vaccines work and how they work in your body and how it makes sense scientifically. So in terms of vaccines, they've been around for actually quite a really long time. So the first vaccine was back in 1796 with the smallpox vaccine. And so these have been around for a very, very long time, but they've worked in different ways in the past. And so there's kind of two main ways that they've worked in the past. So there's the live attenuated viruses, which is basically you take a virus and you weaken it. And that could be through just passaging it over and over again, seeing if it causes less illness, but it's an actual infection. And there's a number of our vaccines that we've been using for a very long time that use this platform to actually make you immune against the viruses. And so that includes the measles, mumps, rubella shot, rotavirus, smallpox, that one way back in 1796, chickenpox, and my favorite, yellow fever, because that's what I used to work on. And then also we have different types of vaccines that we call inactivated virus vaccines. And so we kill them with either heat or chemicals. And so basically this is a virus that can't actually cause an infection. It's just basically the pieces and parts that your body recognizes and say, hey, that's not mine. And so it then mounts immune response. And so some of the vaccines that utilize this technology are hepatitis A, the flu shot, the polio shot, and also the rabies shot. So that's kind of how some of the vaccines in the past have worked. But as you probably have all heard, that the mRNAs vaccines are a whole new technology. And so, I understand that makes people nervous. But from my perspective as a virus researcher, I thought this was really great to see because it makes a lot of sense scientifically. So here we go. We're going to do Biology 101. So let's talk about a couple molecules that are important in this. So DNA is the blueprint of you. You can hear that this is your genome. This is what makes you, you. So this is what's in your cells that says, hey, Carla has blue eyes and kind of brownish hair and everything like that. And so this molecule is a double-stranded DNA molecule. So it's made up of sugars and phosphate backbone and everything like that. So it's a double-stranded molecule. We're not going to get into like all the really deep details of this, but basically just remember it's a double-stranded molecule that makes you, you. The other molecule that we're going to look at too is RNA. And RNA is the messenger because that blueprint, you can't have it all saying, oh, I need to make all of this all at once. And so we need something that says, you know what, this is what I need in my body right now. And so we call that the messenger. And you can see it's different. It's also kind of spirally looking. It's made up of a lot of the similar components, but it's only one strand. And so that makes it a little bit different from DNA, of course. But then also we have protein, which are the doers. So basically you have all these messages, the RNAs running around saying, hey, I need somebody to make these things that do stuff in my body, which is your proteins. And so proteins are made and they look really different compared to the DNA and the RNA. As you can see, there's lots of helices and other things that are going on in this molecule. But basically in proteins, the structure of the protein determines what it does. And so as you can see, totally different molecules going on here, but these are all important in understanding how the mRNA vaccines work. And what's really important too is that we have to kind of remember that there are major differences between these molecules, and we'll talk a little bit about the differences and where they're at. But DNA is the template for making RNA, and RNA is the template for making protein. So it's all interconnected, which is really a cool system to think about in terms of what's going on inside your body. But one thing I really want to point out in this is that you can't take RNA and make it into DNA. That just can't happen in your body unless like there's certain viruses that have like really special ways of integrating into DNA, but like that's not anything that happens with coronaviruses. We'll talk a little about the science of those. So it's not something that happens, but just remember DNA goes to RNA, goes to protein. So now we're going to go to cell biology, and you can see my really rudimentary cell here. I went into science for a reason. I didn't go into art for a very good reason, which you can see. But here's my cell, and these are the two main components of the cell I'm going to talk about, the nucleus and the cytoplasm. And so we're going to talk a little bit about where all these different things occur. So in the nucleus, in our little blue blob, that's where our DNA lives. And so that's where it always stays. It doesn't go anywhere else. It hangs out in the nucleus. And so like I said in the previous slide, we need DNA to make RNA. And so that's where that happens. The RNA is made in the nucleus, and that's the only place it's made. And so once the RNA is made and says, hey, I got this message, and now I need to go make some protein, it has to leave the nucleus and go out into the cytoplasm, in which there is where the protein is made off of that RNA. And RNAs, we don't want them sticking around forever, and they don't, because our cells are turning over all the time, and there's all different messages that need to be expressed across our lifetime. So you probably wouldn't want the same proteins in your body necessarily for every stage of life. So think of how you were at 4 years old versus 40 years old. So we have different expression at different times. So of course, after a little while, and most RNAs only hang around for hours to maybe a couple days, they actually degrade and go away. So that's a really important thing to remember too when we talk about how our vaccines work. So now that we've talked a little bit about us, let's talk about coronaviruses. So COVID-19. So one of the things that I've heard before is that, oh, this is COVID-19 because there's been 18 other coronaviruses and this got really rushed. And why didn't we have a vaccine for the other 18 coronaviruses? Well, the reason why COVID-19 is named COVID-19 is because it was discovered in 2019. And so us as virus researchers are not usually all that creative when we name viruses. And so usually it involves a year. We've gotten away from places and things like that, but that's the reason why it's COVID-19, not because there's been 18 other coronaviruses. So coronaviruses, you have a picture up on your screen. Basically, it's just a little shell of proteins and some RNA that's in there. So there's 4 what we call structural proteins, which is what makes up the actual physical virus itself. And then the RNA is like the little kind of tealish blobs. And there's 29 proteins that can be made from the RNA that's in a coronavirus. As compared to a human, we make anywhere from about 80,000 to 400,000 proteins. So viruses are very simple compared to us. So really they need something to make up themselves, so those structural proteins, but they need a lot of help too. And they get a lot of help by bringing in additional help with what they bring along with, they kind of steal what some of our own cells do. So let's take a look at how that works. Let's make some virus. So again, here's my terrible looking cell. And so once there's an infection, this new little RNA molecule, the red, RNA is red here. So once you get that RNA inside the cell, basically your own cellular proteins are saying, hey, there's an RNA over there, I need to make some protein. And so it goes over there, it reads the RNA, and it starts making these new viral proteins, which then, because we can't make RNA out in the cytoplasm, because remember it happens in the nucleus, those proteins then go back and work on that RNA so that it can make even more viral RNA. And then once you get more viral RNA, you get a lot more protein, and then you start getting virus particles. So that's a really quick overview of how viruses are made. And once the viruses are made, then they go back out and start infecting new cells in your body. So let's take a look then, now that we have all this biological knowledge, we're going to talk about how the mRNA vaccines work. So here's kind of my rough drawing of what an mRNA vaccine kind of looks like. It's a blob of fat, which is those little blobs on the outside, and the RNA is on the inside. So like I said, RNA is kind of finicky. It's not very stable, so that's why it has to have like this carrier molecule to bring it in. And also that's why we usually have it at colder storage temperatures to keep it more stable, so it doesn't just like fall apart into something that can't be used. So this is not a virus in any way, shape, or form. There's no fetal tissue involved with it. I mean, this is a blob of fat like cholesterol and some sugars and some salts. And there's, I think, going to be a slide here in a little bit telling you a little bit more about that. But instead of making the 29 coronavirus proteins, it only makes 1. And so that's going to be that part of the spike that was a part of the virus we saw in the last slide. So again, here's my terrible cell. Basically, the little blob interacts with cells, and then it's going to drop its RNA in. And so, but again, like I said, this is only going to make spike protein this time. So our cell says, hey, there's this thing, I need to make more protein. And so it makes all these spike proteins. So of course, because there's no non-structural helpers in there to make any RNA, it can't make any more RNA as a whole. All it can do is make these little spike proteins. And our cells are really good at having kind of a checkpoint. And so they chop up bits of proteins all the time and put them on the outside of the cell, and to say, hey, immune system, come check me out. And so when the immune system comes and checks out and says, hey, there's this thing, I don't recognize this. This isn't mine. This is what kicks off the immune system saying, I need to make antibodies against this, and start kicking off more and more parts of your immune system to help you recognize that this is not mine, and it helps you become more immune to COVID-19. So we've also heard a lot about that this was rushed, not really accurate on that. So back in 2003, you might remember SARS. SARS was a pretty scary beast. It had a much higher mortality rate than COVID-19. And so at that point in time, scientists were already starting to scramble and try to figure out, okay, how can we make a coronavirus vaccine? And so they started utilizing this research to start making these types of mRNA vaccines back in 2003. However, as you can hopefully remember, SARS went away pretty quickly, honestly. We didn't have a lot of cases even worldwide. And so there was some pockets, but it just kind of petered out in terms of that. I mean, so the scientists kept working on these mRNA vaccines, but it just never came to fruition just because we didn't have SARS-CoV-1 at the time anymore. So that basic research that's still happening over, almost the last almost 20 years at this point. There's still the basic research going on and things like that. So we're in this like vaccine development phase back then, because safety is still always the number one priority when it comes to vaccines. So when COVID-19 came around, we had technology to do this, but what was really neat, especially for me as a scientist, is that we have normally in science, we're very competitive. We always want to be the ones that discover the new big thing. In this case, it was worldwide that everyone started working on the same thing, and money was available because, as we all know, money helps on a lot of things. So this really brought this all together and was able to move things forward a little bit faster just because you had so many people working on it, and also you had a lot of money also involved, and that cooperation was there across the entire world. So of course, though, as vaccine development happens, we still have to go through all the phases of safety, which are in the clinical studies, looking at safety and effectiveness, and then also safety and effectiveness together. And then the FDA does a review along with the CDC from the ACIP, which is the governing body for immunization practices. And so they all look at this data independently, making sure that this all makes sense. And so then they granted an emergency use authorization on that, saying that this is approved for use in an emergency because we know that this vaccine the benefits of it outweigh the problems that happen with COVID-19. So of course, with all these vaccines being approved in terms of the emergency use authorization, they're always continuously keeping an eye on it. And there'll be a little bit more talk about that in some of the later slides from my colleagues. But really, this is not really a new technology. It's been around for almost 20 years at this point. So that's pretty much the end of my science lesson, but just to kind of wrap up some myths and rumors, are the mRNA vaccines a live virus? Nope, they're basically just RNA and a blob of fat, some sugar and some salt. But other vaccines that we've been using for years are live viruses. Will the RNA integrate into my DNA or change my genome? Nope. We have two different types of molecules are located in different areas of the cells. And also our cells just don't have the protein to actually do this in our cells. And also I've heard, is there a microchip? No, there isn't. It's just that RNA blob of fat, salts, sugars. I've heard in some cases that they say it's the size of a grain of rice. And for anyone who's ever given an injection, if you had to actually inject something with the size of a grain of rice, it would be a pretty big needle, and you would know. So with that, I will turn it back over to Nirali, and we'll hold questions until the end. Thanks.
Thank you, Dr. Black. So I'm going to share my screen now, and I'll have Dr. Sullivan start. Just a minute here. All right, are you able to see the screen?
I can't see it.
No, okay.
There you go.
All right. Can you still see it okay?
Oh.
Not anymore. Uh-oh. Okay.
We see her. There we go.
Okay. All right, go ahead and start whenever, if you can see the second slide.
Yep. So as I said before, I'm Dr. Liam Sullivan. I'm one of the adult infectious disease physicians that works at Spectrum Health. And, you know, I've been intimately involved with coronavirus ever since this came out, and been very involved with the vaccine rollout, et cetera, in our community, and especially at Spectrum Health. So just to give you a little bit about vaccines, that was a great overview of vaccine development and how messenger RNAs vaccines work by Dr. Black. I think she did a really nice job of trying to simplify it and break it down into its basic meaning. So vaccines, what they do is their job is to provide us with immunity, because our bodies, when we defend ourselves against infection, we have an immune system, and that's the immune system's job. And every single day we are getting bombarded by invaders left and right. And usually we don't fall sick. And the reason we don't fall sick is because we were granted this, or given this wonderful thing called our immune system that does a phenomenal job at defending us from the vast majority of infections. But sometimes we get infections that do cause us to get sick. And our immune system still is working during that process. And usually we survive those infections because our immune system is able to eventually defeat the invader. And then what we develop from that is what we call immune memory. And some infections provide longer term immune memory than others. And that's because some infectious agents are very good at changing their stripes from time to time. And because of that, the previous memory that our body had may not work for the next time around our body sees that particular infectious agent. But whereas other infectious agents don't ever really change their stripes. And so we can develop good, powerful immunity if we've ever had a natural infection with it. The other way we can develop immunity, though, too, is through vaccines. And vaccines, what they do is sometimes, as Dr. Black alluded to, some vaccines do have an actual infection. They use a weakened version of the infectious agent, like a virus in this case, to cause infection, and our body develops an immune response to it. And so then the next time our body encounters that particular infectious agent, we have defenses ready for it. And then there's some other ways that she alluded to that we can induce immunity through vaccines. The basic premise, though, with a vaccine is that you don't get all the symptoms and the potential complications of the natural infection. That's the biggest difference. A natural infection, you are always at risk for getting the development of symptoms, and sometimes infection can be, like in the case of COVID-19, natural infection can be severe enough to require hospitalization, and potentially unfortunately, way too many cases, it ended in the death of people. Getting a vaccine, though, doesn't do that, because you don't go through the whole process of natural infection with the vaccine, and you only simulate a part of the infection, and enough of and the part that you simulate is the part that gives you long-lasting immunity to that infection. And some people have this misconception that natural infection is always going to give you better immunity than vaccine-induced immunity, and that's actually not true. Some infections, that is the case. No doubt getting it naturally is better and you have lifelong immunity from it. But some other infections, that's not the case, because vaccines are sometimes much better at able to stimulating a more powerful, longer lasting immune response, because the way vaccines are designed, the immune system sometimes in a natural infection has a very widespread, I would call unfocused response to an infection. And sometimes it causes a lot more damage to the person's body than we would like. And then the immunity left over from that may not be very good and may not last very long because it wasn't a very focused response. Vaccines, on the other hand, we lost our slides. Vaccines, on the other hand, give you a very focused immune response. And oftentimes with certain infections, the vaccines have a very good ability to give you a much longer and more potent immune response. We have lost our slides here. I'm not sure what happened. Okay, we can go to slide 4, or 3, I mean. I'm sorry, 3.
That's the right slide.
Slide 3. Nothing like little technical difficulties here.
That's okay, it happens.
Yeah, it does, exactly. That's the downfall of technology, is that sometimes it doesn't work the way you want it to. So I can kind of see it. I'll start talking about it. So when we have vaccine-induced immunity, that brings up, so how well do these vaccines for COVID-19 work? And thus far, they have worked phenomenally well. I mean, I think it's been beyond our wildest expectations. At the beginning of the pandemic, when they were talking about vaccines and how good they were going to work, we thought, well, if we get one that's 50 to 60% effective, we would be very happy with it. Well, we have 2 vaccines that clearly far exceed the 50 to 60% one. And then the other one, the Johnson & Johnson vaccine, far exceeds it as well. It's very hard to do a direct head-to-head comparison between all the vaccines for various reasons, but suffice to say that all 3 of them work remarkably well and are definitely starting to have an impact on infections around the country, and thankfully finally starting to see a significant impact on the infections here in Michigan. So with the messenger RNA vaccines, the Pfizer vaccine and the Moderna vaccine, the clinical trials for both of them demonstrated what we call an efficacy of about 93 to 95% in both trials. Now, efficacy is a little bit different than effectiveness, because efficacy is what you establish in a clinical trial, because all the conditions in a clinical trial are perfect. And the clinical trial can only enroll about 30 to 40,000 people. You start getting above that many people, it becomes too hard to run one bigger, because the logistics and the money required to do a clinical trial of even 30 to 40,000 people is massive. So it's a huge undertaking. So conditions are somewhat perfect in a clinical trial. And so we established what we call efficacy. But then when you roll out the vaccine into the real world, obviously conditions change. And that's called effectiveness. And so the real world effectiveness, and now we're starting to see data come out on when the real world effectiveness of these vaccines are. And thankfully, the real world effectiveness is proving to be every bit as good as the clinical trial efficacy was. Some early studies that are coming out are showing that vaccines are 93 to 95% effective at either preventing symptomatic COVID or keeping people out of the hospital and keeping them from dying. Of course, there's going to be some cases where they're going to, where people are going to break through. We call that vaccine breakthrough, and that was not unexpected. No vaccine is going to prevent 100% of all infections in all people. There are lots of different reasons why some people may not have had a good response to the vaccine. Sometimes they may have gotten a heavy exposure to the virus that sort of overwhelms their defenses and can cause an infection. But the cases that have been associated with a vaccination in vaccinated people have been very, very mild cases, and it's prevented infection or even symptoms in the vast majority of people. So these vaccines have been phenomenal in their real world use and effectiveness. Next slide. And obviously safety is safety is obviously a big focus in vaccines. And as Dr. Black alluded to, during all phases of vaccine development and clinical trials, vaccine safety is focused on very, very closely, from phase 1 all the way to phase 3 trials. And the messenger RNA vaccines did not have any major safety issues with them at all in their clinical trials. And the Johnson & Johnson one actually did not have any major safety issues with it at all. We'll talk about the blood clot issue with the Johnson & Johnson one in a minute here. But most vaccines, you're going to get minor side effects from any vaccine is to be expected. Injection site pain, you're getting a needle stuck in your arm and a substance injected in there. It's going to cause some discomfort at times. Some people, it's a little bit worse than others. And then it's not unusual for people maybe to have some systemic symptoms for 24 to 48 hours after vaccination. That's because your body is reacting to a foreign invader. And sometimes people will feel some effects from that because your immune system releases chemicals, and these chemicals can sometimes make you feel kind of tired, maybe give you diffuse body aches, low-grade fever, etc. But symptoms will wear off very, very quickly, and you'll go back to feeling normal within 48 hours. So those are to be expected with any vaccination, and those side effects that we saw with the mRNA vaccines are not any different than previously seen vaccination trials with the vaccines that we already have in use and that have been in use for a very long time. But suffice to say, with these mRNA vaccines, there's been no major safety issues identified during the trials, and even after the clinical trials, there has been no major safety issues found with them. And there's been well over 1 billion doses of the mRNA vaccines administered worldwide, and they have proven to be every bit as safe with the widespread rollout as they were in trials. Next slide. So Johnson & Johnson. So Johnson & Johnson in their clinical trial, people have this perception that Johnson & Johnson's vaccine is not quite as good because its efficacy was only 66% at preventing moderate to severe COVID-19 and 85% of severe disease. However, you have to keep in mind that Johnson & Johnson's clinical trial was done at a different time than the messenger RNA clinical trials, and it was also done in a different population. A lot of their data came from overseas in South Africa and Brazil, where there was widespread circulation of some of the variant viruses. So that probably contributed to some of the reduced efficacy noted in the clinical trials. And then in the Johnson & Johnson trial, there was much, much higher rates of COVID-19 disease going on in the United States at the time of the trial in the US. But and Johnson & Johnson has some advantages. It's only a 1-dose vaccine. You don't have to get a second dose. So it's a one and done. Its storage requirements are a lot easier. And so some of the logistical issues with Johnson & Johnson make it a much easier vaccine to use than the 2 messenger RNA vaccines. It still provides a very high degree of protection, particularly against severe disease and death. In the trial, nobody died from the Johnson & Johnson vaccine due to severe COVID-19 disease. And there were no hospitalizations in the trial as well. Now, recently, you've probably all heard there's been a pause because there were several instances of rare blood clotting associated with an extremely low platelet count in people. And particularly this was seen in women aged 18 to 49. And so the CDC and the FDA chose to pause it because they wanted to investigate this more closely. And they also wanted to make clinicians aware that this disorder needed to be treated a little bit different than standard blood clotting disorders. And so that was one of the reasons they paused it, so they could identify more cases and see if this truly was a signal and was something that they had to address. And number 2, make sure that clinicians were aware of it and what to look for and how to treat it if they did find cases of it. And after they reviewed it and did an intensive review of it, they did find a few more cases of it, but it wasn't widespread, and it still is extremely rare. So there's the estimate right now is about 7 per million in women age 18 to 49, and over 50, 0.9 per million. Now, one of the things I want people to keep in mind is that when you look at blood clots associated with COVID-19 disease, the rate of blood clots associated with getting COVID-19 is significantly higher than these rates of blood clots associated with the Johnson & Johnson vaccine. And I don't want to make light of this issue with the Johnson & Johnson vaccine, because it's certainly something that everybody should consider when they get vaccinated. I mean, now we're in a position where you can choose the vaccine you want because we're flushed with vaccine. We have enough supply of all 3 vaccines, and people can choose which one they want. So if you are a person and you're nervous about the Johnson & Johnson vaccine and you don't have confidence in it, or you're concerned that you could get this side effect, then by all means, please get a messenger RNA vaccine, because there's plenty of it to go around. But I think the major group of people that need to really look at the Johnson & Johnson one are women 18 to 49. And if you're a female 18 to 49 and you have the choice to get an mRNA vaccine, that's probably the best thing to do. But I think everybody else, the Johnson & Johnson vaccine is exceedingly safe. And even in women 18 to 49, if you have no other choice, it is still an extremely rare thing to happen. And I think it can be given safely going forward. And I'm glad that we have resumed the use of this vaccine. And one thing, I think some people have this perception that this maybe shows that we rush these vaccines. Well, these issues were identified through the Vaccine Adverse Event Reporting System, or the VAERS. VAERS is in place just for this instance, because clinical trials can't always identify extremely rare side effects. Like I said, they only do 30 to 40,000 people. When you take a clinical trial then and you're rolling it out, go from a clinical trial out into the population, you have millions and millions of people who are getting this product. And I don't care what medication you're using, whether it's a painkiller, an antibiotic, a vaccine, a cancer drug, or whatever, once you start using it in millions and millions of people, there's always the potential that you could see extremely rare side effects that you would never identify in the clinical trial, because a clinical trial just can't enroll that many people. And there are a lot of factors that come into play why sometimes you will see these rare side effects come out. So that's why we have VAERS to help identify them and address them and treat them appropriately. And I think that was done in this case. Next slide. Just an overview of what's in the vaccines. I mean, I think one of the things people have always been concerned about with vaccines is, well, what are the other ingredients in them? And the ingredients that's always raised alarm in the past are the preservatives in vaccines. Thimerosal would be the biggest one that's been in vaccines in the past. And thimerosal is a mercury-containing compound, and that's always been a point of contention with a lot of people with vaccines because they're concerned about the preservative potentially being toxic to people. Well, these vaccines do not have any preservative. None of them do. All three of them have relative. I don't want to call them simple ingredients, but as was alluded to before, the messenger RNA vaccines have what we call fat globs. They're these little particles made up of fatty compounds, such as cholesterol and a bunch of other very complicated names that are hard to pronounce there. And then the Johnson & Johnson one does not have any preservative. It just has a bunch of salts in it and some sugar in it to help stabilize, keep it stable for a period of time. But none of them have preservatives. So I think that you can dismiss the idea that they have these other compounds in them that are potentially toxic. Next slide. Like I said, after vaccination, having a little bit of pain at the site of injection is not unusual at all. So don't be surprised if your arm is sore for a day or two. And then, a significant amount of people will develop some very mild systemic symptoms, body aches, fatigue, etc., maybe a low-grade fever. Again, those are going to go away, but the vast majority of people, they're going to go away within 24 to 48 hours, sometimes maybe a little bit longer. And then anaphylaxis, which is an allergic reaction, is exceedingly rare. Again, with any compound we use, medicine taken by mouth, or even the food you eat, there's always a potential for anaphylaxis if you're eating something your body has never, ever seen before. And anaphylaxis, those are allergic reactions. Those are completely unpredictable the vast majority of the time. And so, we found with the Pfizer and the Moderna vaccines, they're exceedingly rare, only 5 per million doses administered for Pfizer and 2.8 per million doses administered with Moderna. There's a very, very rare anaphylaxis, and people have not died from these reactions. All vaccine sites are very well prepared for this. And in case something happens, they can deal with it and treat it appropriately right at the site of time of vaccination. But these are exceedingly rare events. Next slide. Lastly, I would like to say that if you've had COVID-19 and you've recovered, do you still need a vaccine? And the answer is yes. Vaccines, as I alluded to before, oftentimes give you a much more focused immune response. They will augment and help your previous immunity from COVID-19 if you had natural infection. And so we would really encourage people, if you've had a COVID-19 infection, you've recovered from it, yes, you do have some immunity from it, but get vaccinated because it's going to boost that immunity even more and likely give you a much longer immunity to COVID-19 than natural infection alone will. With that, I will hand it over to Dr. Bora.
Thank you, Dr. Solomon. So we're going to just transition a little bit. I'm going to take a quick pause before I go into some frequently asked questions. So talk about the state of COVID in Kent County. I just want to give you a picture for where we are in terms of cases and where we are in terms of vaccination. All this information is available on our Kent County dashboard on Access Kent. So if you want to look at it for yourself, feel free to go to that website. That website is updated daily at 7 p.m. And so that the information you're looking at is as accurate as we can get it. And all the information pulls from the state dashboards as well. So it's updated very regularly. So I'm going to go, as we get our slides set up, I'm going to go ahead and get started a little bit just talking about cases of COVID. So right now, as you've heard, we're in the middle of our third surge. Our cases are trending downwards, which is wonderful to see. And so you can see on the slide on the graph on the left, it looks at the number of cases per day. And you can see that we're trending down. We have about an average of 260 some cases per day, which is better than what we were seeing earlier on. The one on the right, that chart on the right, looks at patients who've been hospitalized in Kent County because of COVID. And you can see there are patients who are hospitalized because of COVID and those that are in the ICU. So while we are trending downwards, you can see that there are still quite a few people in our hospitals and quite a few people in our ICU. So people are still getting very sick. And, it's been kind of difficult to see that recently we've had more children who've been hospitalized because of COVID than in any other point of the pandemic. And so this is another reason why we feel that vaccination is so important. Vaccinating adults around children who are not yet eligible is really the only way and the best way, one of the best ways to protect them from getting COVID and having to deal with the possible effects that they may experience. Next slide, please. So this slide, again, is on our dashboard too, and it looks at the percentage of our population that's had doses of vaccine. So you can see right now, this was accurate as of this morning. So from the end of yesterday, 55.5% of Kent County residents had received at least one dose of a vaccine. And nearly 46% have been completely vaccinated. So this is really exciting for us to see. And you can see the breakdown by different age group on how many people, what percentage of people in different age groups have been vaccinated. And looking at our 65 to 74 population, nearly 78% of that population has been partially vaccinated, not fully quite yet. But so we know that we've already started seeing decreases in infections, decreases in deaths, and decreases in hospitalizations in these age groups. It's also really encouraging to see that nearly a third of our population aged 16 to 19 has had at least one dose too. And so we're really hopeful that people can start getting back to normal and participate in sports and their graduation activities and all of these things because they are vaccinated. Next slide, please. And so now I'm going to transition into some questions that we hear quite frequently. So hopefully we'll answer some questions that you have, but definitely want to hear more at the end of this. So one that I hear a lot is, what if I'm pregnant or breastfeeding? And I know Takia alluded to this at the beginning of our session. So we really recognize how important all decisions that people make, throughout life, but especially when they're pregnant, especially when they're breastfeeding, when you're really concerned how this is going to affect your fetus, your baby too. So what we do know is that getting infected with COVID during pregnancy has a higher risk for the woman to get severely ill. There's also a higher risk of having preterm birth and other pregnancy complications. So we know that's the case, and that is why we are really encouraging women who are pregnant or breastfeeding to become vaccinated. So over 100,000 women who are pregnant have been enrolled in a registry and have received the vaccine. This registry looks at the safety and it just follows these women over time, so we understand more information about what's happening. They reviewed about 35,000 of these women who received the vaccine between December of last year and the end of February this year, and they did not show any safety concerns from the vaccine. And just a few things that we do know about the vaccines. So COVID vaccines are not likely to pose a risk to the person who is pregnant or to the fetus, nor to the breastfeeding infant. We don't know of any biological way that would happen. There are antibodies so some benefits of vaccines are also the antibodies that your body makes in response to the COVID vaccine can be passed on to the baby during pregnancy. And they found that this happens especially during third trimester. If a person becomes immunized during that time, that the baby can be born with some protection already against the virus. Antibodies can also be passed on through the breast milk to provide some protection against COVID to the newborn. So this is also very exciting because this, new and young infants have a poorly developed immune system, and so they are more susceptible to infections in general. So any protection that can be provided to them is really helpful. The COVID vaccine itself, if any is able to pass through breast milk from the COVID vaccine immediately after being vaccinated, the vaccine is so unstable. It requires such cold temperatures to be, even stored that it will be inactivated if it's swallowed from the baby, from the acidity of the stomach. It's not going to last in the newborn that way. So vaccinating pregnant people and breastfeeding women has been supported by many different medical societies and medical organizations. But always, if you're still uncertain, if you have questions, which is definitely understandable, please talk to your doctor. Next slide, please. So another question that we have heard quite a bit is, can getting the COVID vaccine affect fertility? So there's been a lot of information in social media and online that has been put out by not reputable organizations or individuals. It has been refuted, found to be false by many experts in the scientific and medical communities. So there's no biological way that these vaccines would increase the risk of infertility or miscarriage. There's no way that we have found that they would harm the placenta. So looking back at the information that we do have, looking at the clinical trials for Pfizer, they found that 23 women actually became pregnant during the trial. They specifically did not include women who were pregnant in the trial because most studies do not include pregnant women. early on when they're trying to get their initial information, but these women became pregnant during that. There was one miscarriage, but this was in a woman who actually had not received the vaccine. Next slide, please. And so I just wanted to show you, I'm not going to read all of these to you, but these are statements from these organizations that support COVID vaccine. And again, they state that there's no evidence that COVID vaccines can negatively affect fertility for men or for women. And I know you can read, but I'm going to read the American College of OBGYN statement to you, just because that is an organization that is really charged with ensuring the safety of pregnant women. They make recommendations for prenatal care, for women considering pregnancy, for postpartum care. And so they're a very trusted and reputable source of information, as is the CDC, but the American College of OBGYN really focuses on this particular population. So they say, as experts in reproductive health, we continue to recommend that the vaccine be available to pregnant individuals. We also assure patients that there is no evidence that the vaccine can lead to loss of fertility. While fertility was not specifically studied in the clinical trials, no loss of fertility has been reported among trial participants or among the millions who received the vaccine since their infertility and since their authorization, and no signs of infertility appeared in animal studies. So loss of fertility is scientifically unlikely. So that for physicians and the community who are advising their patients, these are really reassuring statements for all of us to hear. So next slide, please. So again, some other questions that we hear a lot. So what if I have a chronic illness, or what if I'm immunocompromised? So people with a chronic illness, so illnesses like diabetes, like chronic kidney disease, like high blood pressure, people with these health conditions are automatically at higher risk for becoming more ill with COVID. So we know that these people would significantly benefit from not getting the actual virus, but they would benefit even more than some from getting the COVID vaccine. So we do recommend that people with chronic illness get the COVID vaccine. So some people are immunocompromised, so their immune system does not work quite as well. This could be for multiple different reasons. They could be undergoing treatment for cancer, other health conditions that they have. So these people are also at higher risk for severe illness because of COVID. So again, there's limited data on how effective the vaccines are, because for a vaccine to be the most effective, you need to have a really good immune response to that vaccine. And that is what happens in most of the time. If someone's immune system for some reason is not responding quite as well, they may not have as robust of a response to the vaccine. But because they are at extremely high risk, if they were actually to get the virus, they were at much higher risk of becoming severely ill. Even some protection that they would get from the vaccine is going to be helpful for them. So we would recommend that people who are immunocompromised do get the vaccine. But even after they get the vaccine, it would be helpful for them to remain vigilant. So to continue to wear a mask in situations that are high risk, to maintain distance, things like that they've already been doing to protect themselves. Next slide, please. So who should not get the mRNA vaccine? So pretty much everybody can get the vaccine, but there are a few individuals who should potentially not get the vaccine. And so these are people. So if you have a severe allergic reaction, like anaphylaxis after the first dose of the vaccine, please don't get the second one without speaking to an allergist. If you have an immediate allergic reaction to the first dose of the vaccine of any kind, again, please don't get that second dose right away. In some situations, another type of vaccine like the Johnson & Johnson may be okay in some situations for that second dose. If someone's received a monoclonal antibody treatment for COVID, please wait 90 days after that in order to get the vaccine. But if you've had COVID, you don't need to wait those full 90 days. Just make sure you've gone through your first 10 days, you're not infectious anymore, then you can go ahead and get the COVID vaccine. Next slide, please. So what can you do? So after 2 weeks after you're fully vaccinated, it really opens up a lot of things. You can feel more comfortable gathering with other people who are vaccinated in small groups without wearing a mask. You don't have to quarantine if you're traveling in the United States. You don't need to quarantine at all if you're exposed to someone who has COVID-19. If you do develop symptoms though, even if you've been vaccinated that you think are consistent with COVID, you should still get tested, you should still isolate. Like Dr. Sullivan was mentioning earlier, nothing is 100% effective in the real world. And so there is, people who have been fully vaccinated, there's still a chance you can get COVID. It tends to be much more mild and people don't get nearly as sick, but there is that chance they can transmit it. So if you do start developing symptoms, then go ahead and please get tested for COVID. I also want to share with you a few things before we end on what's on the horizon. So, we expect that the Pfizer vaccine will be available for children aged 12 to 15 sometime in the next 1 to 2 weeks. And we heard recently that the vaccine for, children ages 2 through 11 could be available by September of of this year. So exciting things that are coming. Next slide, please. So really, what's the bottom line? You know, getting vaccinated is going to keep you safe. It's going to keep your family safe. These vaccines are extremely effective. They work really well at protecting you from the virus. You know, and the more people that get vaccinated will help you and your family and all of us return to normal. So thank you. Next slide. I don't know if I have anything else. Oh, no, that's it. So thank you all for joining us. Thank you, Darius, for having us, and to the panelists. I really would like to transition right now from our talking to you to a chance for you to really ask us some questions. So if all of you could turn on your video for me, thank you. All right, I am going to start looking through some of these questions here. So there's a question for Dr. Sullivan. What about thrombocytopenia following Pfizer and Moderna vaccines? I'm a 28-year-old woman with a history of idiopathic thrombocytopenic purpura. And so there's some hesitancy about getting any COVID vaccine. What are your thoughts?
So with the messenger RNA vaccines, the blood clotting issue has not been seen at all. So that has been not a concern at all with any of the mRNA vaccines. Extensive review of the safety with them in the clinical trials and with the real world data has not revealed any issues with clotting or with thrombocytopenia in the messenger RNA vaccines. So I think if you're a person who has a history of thrombocytopenia, I think you can feel very safe that if you get a messenger RNA vaccine, you are not going to experience any of these problems. Clearly, you know, the J&J vaccine would not be a good option for you. I think because of you already have underlying thrombocytopenia, and there's this potential thing, particularly in females in your age group, where this rare side effect could happen. So avoidance of the J&J vaccine for you would obviously be the best choice. But I would feel completely 100% comfortable recommending an mRNA vaccine to you. I think they are very, very safe, and we have not seen this clotting issue at all, with or without thrombocytopenia with the mRNA vaccines.
All right, thank you. This next one says, can you speak for a minute about vaccinated individuals and transmission of the virus?
So far, you know, that's kind of been one of the outstanding questions in all this. And I think that's one of the things a lot of people say, well, I got to get vaccinated, I still got to wear a mask. Well, you know, the clinical trials, you know, they did because we needed, this disease was so widespread and we needed to start getting people vaccinated. That's the one thing that the clinical trials couldn't quite look at yet. Now, there's a lot of observational trials going on right now where they're looking at the issue of virus transmission in vaccinated individuals. And what they are studies are starting to come out showing that virus transmission has significantly cut down on people who have been fully vaccinated. You know, the amount of transmission that they are seeing with vaccinated individuals, it's almost zero, to tell you the truth. It's very, very little. And so that we sort of expected that was probably going to be the case. Now we're getting studies that are confirming that that's the case, that people who are vaccinated are not going to transmit the virus. Now, can I tell you 100% that 100% of people who are vaccinated are not going to transmit the virus? Of course not. Of course, there's going to be a little bit of very low transmission with some people who are vaccinated. But I think it's safe to say that the vast majority of the people who are fully vaccinated are at this point in time, the evidence is mounting and continues to mount that they are not going to be major transmitters of the virus, that they're going to transmit little, if any, virus to other people. But for right now, because there's so much widespread virus transmission that continues to go on in our community, we still have a large percentage of the population that's not vaccinated. As Dr. Bora pointed out, only 55.9% of people in Kent County have had at least one dose of vaccination. So at least that's 45% of our population that's not vaccinated yet. We still got a lot of vulnerable people in the community. And if you're walking around, you aren't going to walk around with a big label on your head saying I'm vaccinated. You know, nobody knows your vaccine status. And that's why we want people, when they go into crowded settings, et cetera, to please continue to wear a mask, whether or not you're vaccinated at this point in time, because we just don't have enough people there yet. And we have widespread transmission, and that's why we want you to do that.
Thank you. So this next question says, do we know about protection, longevity expectation of vaccine? If there are boosters later, will we need to get them from the same original company? Do you have thoughts on that, Dr. Sullivan?
Yeah, so, you know, that's a very good question, and that's one that's yet to be answered. I know you've heard Pfizer and Moderna come out and saying that they need boosters. I think that's a little premature, both of them, to announce that. You know, when you listen to vaccine experts, people who do vaccine research, none of them are committed to saying that we're going to need a booster at the 1 year mark at this point in time. I think they all feel that at some point it's probably going to be necessary because of all the variants that have been circulating. But when that's going to occur, nobody knows yet. That's an active area of research. You know, in the clinical trials so far, Pfizer and Moderna reported data from 6 months into their clinical trials about a month ago, and they found that all the people are maintaining a very high level of immunity thus far in their clinical trials, and they've continued to have hardly any infections in the people who are vaccinated in their clinical trials. So they're maintaining 6 months out, they're maintaining a very high level of immunity. I think a lot of people think that if we're going to require boosters, the 1 year mark is the soonest. But I don't think a lot of vaccine experts are convinced that that's going to be necessary at the 1 year mark. And then the other question about if you get vaccinated, let's say you get a Pfizer vaccine, is that the booster you're going to have to get? That's another area of active research. Actually, there's a big trial going on in England where they're looking at, okay, we're going to give people their first dose of vaccine with either Pfizer or AstraZeneca. Then the second dose of vaccine they're going to get 6 weeks later is going to be the opposite of what they received the first time, you know, sort of mixing vaccines. You know, I think they're looking at to make sure that it's safe and see how well it works for the immune system, because maybe getting 2 different types of vaccines is going to generate a little bit better immune response. So that's what that study is looking at. So while we don't know the answer to that question, I would dare say that the answer is probably no. You probably will be able to get a different vaccine if and when boosters are required. But you know, more information will be coming out on that. I think later on this year we'll hear a lot more about that.
Yeah, and if I can jump in really quick too, and not so much with boosters, but because of the mRNA technology that we have now, if we continue to get variants that might start to escape in terms of vaccine efficacy, at least with mRNA vaccines, it's a lot easier to mass produce mRNA instead of having to grow up a virus and set in a chicken egg and all these other things. This technology makes it a lot easier to kind of make some changes in the RNA itself and get that vaccine out quicker.
I think Dr. Black, I think you may have started answering the next question. I'm going to start this one off with you, but it says, do you know why the mRNA vaccine type was chosen for the COVID-19 virus versus the other options like live or inactivated viruses like our previous vaccines?
Yeah, so I did kind of hit on that as I just started talking. So mRNA is a lot easier to produce in labs, and just because you can make the sequence exactly what you want it to be. And so that makes it a lot faster in terms of having to grow a virus and then keep passing it to make sure that it's not it's not going to produce further infection and all of that, and having bad symptoms. That takes a lot longer to figure out, whereas, you know, you have one protein and that's it. And so it makes it a lot faster to go. I mean, as a person who used to work in the lab, I used to make RNA almost every day. It was, you know, a couple hour process from start to finish, honestly. So that's something that can be done pretty easily.
Dr. Sullivan, do you have anything else to add?
Yeah, I'll add too, just to piggyback on that. You know, with the Johnson & Johnson vaccine, you know, it's an adenovirus vector vaccine. That one's actually very easy to mass produce as well and very easy to manipulate. You know, I think what you need to look at it is, you know, the messenger RNA vaccines have this fat glob carrying the messenger RNA into the cells. The adenovirus vector vaccine is sort of a very similar concept, except it's just doing it in a different way. It uses a different delivery mechanism. Instead of using a car, it's using a bus, so to speak. You know, you're using a virus that can't replicate, in this case, an adenovirus, to deliver that genetic information into the cells, that messenger RNA for your cells to make that spike protein. And like the mRNA vaccines, it's very easy to manipulate the adenovirus vector vaccines as well, and mass produce them and alter them if they need to be altered. And then the adenovirus vector vaccines have the advantage over the mRNA vaccines is that their storage requirements are much easier, and logistically they're a lot easier to produce and then mass produce and ship all over the world. You know, because some places don't have the storage capacity for the mRNA vaccines. Adenovirus, you just need a regular freezer to store it.
Thank you both. All right, this next one's a good question because I've heard it a lot, so I'm looking forward to your answers. Says the FDA, still even with millions of vaccinations, has not deemed this vaccine safe for general use. It is for emergency use only, and why? And then it says, other scientists that work for pharmaceutical companies told me they will not risk it for at least 4 years.
So I can answer that question. So one of the things about, you know, it's interesting you asked it because I just heard a good podcast about this yesterday. So when the FDA fully license a product like this, whether it's a medication, a vaccine, et cetera, they've issued this emergency use authorization. It's now up to Moderna, Pfizer, and Johnson & Johnson to submit the information to FDA for full licensing. It's really up to the companies to determine when they want to ask the FDA, okay, we want this thing to be fully licensed. As long as Pfizer, Moderna, and Johnson & Johnson don't do that, the FDA is not going to automatically give them, because that's a whole different process. And apparently requires, it's a much more bureaucratic process, if you will. There's a bunch of other stuff that I's they got to dot and T's they got to cross when they do that. So the individual companies play a role in that whole thing. One thing I did hear, though, is that Pfizer is probably going to be submitting for full licensure at some point this summer. So I did hear that, and that the expectation is that Moderna is going to go for it later this year as well. So don't at all be surprised if you hear Pfizer and Moderna are asking FDA for full licensure of the vaccine. So I think now, again, I think both of them are probably in a position, there's been so much data, real world data gathered from these products that they feel comfortable, yes, if we go submit it, we're going to get it fully licensed. Now, one thing I will say is that most vaccine trials, the reason vaccine trials go on for such a long period of time, certainly safety is always part of it. You're looking at safety at phase 1, phase 2, phase 3, and all the way through phase 3. And phase 3 tends to be the longest clinical trial. That's always a focus of a vaccine. But the major reason that vaccine trials go on for several years is the safety stuff they usually can determine in the first couple of months. If you don't have any side effects from vaccines after the first 60 days, to see something after that is exceedingly rare and unusual, and it really just doesn't happen. If the vaccine's going to get derailed in the phase 3 trial, it's going to get derailed usually in the first 60 days of when people receive the vaccination. They usually don't get derailed after that. If they get derailed after that, it's going to be because they don't protect people very well. And by that, I mean, they don't offer a long period of protection, because that's why they do the vaccine trial. They're looking at several years. So they want to see, they continue to follow the people and they say, okay, how long is this providing immunity to people? And I'll give you a good example, the shingles vaccine, Shingrix, the brand new one. That clinical trial lasted 5 years. The reason it lasted 5 years is they took those participants, those 30,000 participants, and they followed them for 5 years to see how many people got shingles over those 5 years. And that was the major thing they kept looking at as the trial went on. The safety was already well established, in the first year of the trial, or the first 60 days of the trial, and they weren't worried about that anymore. They kept looking at it, but it wasn't a concern anymore because it was safe. Now they wanted to say, okay, how long are people going to have a good immune response from this vaccine? That's why vaccine trials typically go on a long period of time. The safety is usually established very early on within the first 60 days, and now they want to just see how long is this going to protect people. And these trials for Pfizer, Moderna, and Johnson & Johnson are still going on. They haven't ended. They're going to go on for a couple of years before they're completely over with.
All right, thank you. This next question says, there seems to be a fear or possibly misinformation circulating right now that fully vaccinated people are catching COVID and dying. Is this true?
That is not true. There are some people that are fully vaccinated that have caught COVID. We've seen a couple cases locally in the hospital here. They've been identified all around the country. The vast majority of them, they actually are discovered incidentally, because what we do is when patients get admitted to the hospital, regardless of what reason they're getting admitted to the hospital, I know at Spectrum we do this, we swab everybody for COVID because we want to know if they have COVID when they get admitted. So regardless of their symptoms or not, they get swabbed. And most places across the country are doing that. So what we're doing is we're picking up these incidental cases. People are coming in, let's say they're coming in for a diabetic infection in their foot, for instance. I'll give you an example. And they have absolutely no symptoms of COVID, and they test positive for COVID despite the fact that they're being fully vaccinated, but they never go on to develop any symptoms. So we're picking those up, but that's not surprising that, the vaccine's doing its job. It's preventing people from getting symptoms. Sometimes people are going to get it. They may be positive for the virus a little bit. That doesn't mean you're picking up live virus either. Remember, the tests that we use to diagnose people with COVID are picking up genetic material from the virus. That could be from dead virus or live virus. And so the vaccinated people, the vast majority of them are not sick at all. A few of them have been getting sick. Yes, there have been some breakthrough cases where a few of them have gotten sick. And there have been a small number of cases in the United States where vaccinated people have died from severe COVID infection. That's in the CDC's investigating those cases. And so far, the majority of them are probably due to people just who did not have a very good vaccine response for one reason or another. They have underlying immunodeficiency, they're on medications that affect their immune response to the vaccine, et cetera. Or they have other diseases that contribute to their risk for COVID. But that is not a true statement. There has not been a lot of cases and not a lot of people dying from it. As a matter of fact, the opposite has been the case.
Great, thank you. I'm going to come back to the question on transmission of virus. I just want to get through some of these questions about the vaccine first. So it says, why is the J&J vaccine only one dose? If there were a second dose given, would it provide higher effectiveness?
Johnson & Johnson's actually doing a second clinical trial to answer that very question. So their clinical trial on the one dose, it was called Ensemble. The Ensemble 2 trial, which they are doing with 2 injections 56 days apart, is ongoing right now. We'll probably hear about the data from that trial sometime this summer. It's a very good question because that might very well be the case. It could, is it going to happen? We'll see. It wouldn't shock me if that two injections does give you a higher level of protection with the Johnson & Johnson, but we have to wait and see.
And one of those study sites is right here in town. So there's
exactly, yep.
There are people enrolled right here in town for that study. Does the review criteria for vaccines change based on the age of the population where they will be administered? For example, is there more stringent review for vaccines given to teens and even more for adolescents?
So the difference between the major difference between the trials for adolescents, teens, elementary age school kids and teens has to do with the dose of the vaccine they're getting, because young people's immune systems are a little bit different than adult immune systems. So people, generally speaking, 18 and older, although the immune system doesn't have an exact cutoff at 18. Most people probably have a fully developed immune system. It's fully matured by the time they're 14, 15, right in that range. But because we consider adults 18 and older, that's how we do things. It's sort of an arbitrary number. But really, it's in the younger people, the people less than 12, that their immune systems are still kind of developing. And so their vaccine, with other vaccines, the schedule of vaccine for them is different than it would be for an adult because of that little immaturity in their immune system. So when they do a trial in kids that age, they have to look at different dosing schedules and different doses. And obviously they're looking at safety too. I mean, they want to make sure, okay, are these doses safe at this period of time? How many doses do we got to give, et cetera? So it's a combination of all those things, but dosing is probably the biggest reason why we haven't seen, because the dose you use in adults is probably going to be different than what you use in somebody who's 5 years old. So that's kind of what they're doing right now. Pfizer and Moderna have launched trials in the young kids right now to establish what the best dose is, what the best schedule is, et cetera, and obviously looking at safety too.
Right,
as our time comes to an end, we'll just take a look at a couple of more questions. And Takia, just a heads up, we'll ask you to close us out and maybe share with us from your perspective any information you'd like to pass along regarding COVID-19 vaccinations. And Dr. Bohr, I'm not sure if you have a question or two you want to address before we close out.
Nope, we have questions for Takia. What advice do you have for people who are family planning, breastfeeding, et cetera? So we'd love to hear your thoughts.
I'm unmuted, okay. Initially, like I said, I was very concerned about getting the vaccine because it was in December when I actually decided to get it, and there was no recommendations or guidance from ACOG. And when I called my OB-GYN, they were like, pretty much is your choice. And so I made the decision to get vaccinated, ultimately because of my baby. In my head, I knew I would mount a response and antibodies would be formed, and I would hopefully give my baby some passive immunity through breast milk or antibodies through breast milk. So I chose to get vaccinated, and I don't regret it. I'm actually happy that everything came out and confirmed what I thought originally. But my advice would be to get vaccinated, because ultimately, for me personally, I was concerned about the side effects, or not the side effects, but me getting COVID and what that would look like. I have some risk factors myself that could cause me to have severe disease. So the fear of the vaccine was not greater than the fear of getting COVID for me personally. So I decided to go with it, and I feel fine. I don't have any side effects. Initially, after the second dose, I had some of those viral symptoms, but they went away within the first day. My baby's doing great. Yeah, I would recommend go for it. Did that answer the question? I kind of forgot it.
I think so. I definitely think so. Thank you, Takia. Just any last words that any of our panelists would like to share with the audience today?
Yeah, I would just like to say, you know, one thing is that the mRNA, particularly the mRNA vaccines, you know, I can appreciate some people's hesitancy with the J&J vaccine because of the whole clotting issue. Keep in mind that it's exceedingly rare, a very, very rare complication, and that your risk of blood clots with COVID is astronomically higher than it is with the vaccine. Nevertheless, if you're a female 18 to 49 and you have the choice to get an mRNA vaccine, that's probably the best choice for you if it's available to you. But something is better than nothing. I want to emphasize that. Number two, if you're young people out there, there's a lot of young people who are, you know, you're at that age, man, you're invincible. I remember what it was like to be 25 years old. You thought you could take the world on and nothing could strike you down. Well, I'm going to a couple things. Number one, we've seen a lot more younger people in the hospital right now. And I've seen some very, very sick young people. And I've had a couple die that should not have died at the age that they've died at because they got COVID-19. So don't think for a minute because you are young and healthy, you can't get severe COVID-19. You can prevent that by getting vaccinated. And I would encourage you, please get vaccinated, not only for yourself, but for the community. Because if you don't get, yes, maybe you're going to get a mild illness, but you could still spread the virus to other people who are much more vulnerable than you because you're not going to know the status of them or the people around you. So please keep that in mind. I think as a community too, you should think about our responsibility to other people around us. These are safe and great vaccines. So I would encourage people, please get vaccinated.
Yeah, I completely echo the thoughts of Dr. Sullivan. I mean, one of the big reasons for me to get vaccinated was because of my kids. I know that they can't get vaccinated at this point, and really looking at them, I want to make sure that you know, there's COVID long haulers. Like they don't always get better right away. And I can't imagine, you know, bringing something home from work and giving them COVID. And so that's one of the really big reasons why I got vaccinated. So again, do it for your family, do it for your friends, do it for your community.
Dr. Boer, there appears to be 2 questions remaining, and we have about 2 minutes left. Let's see if we can address those.
Sure. So this question is about transmission of the virus. Can the virus be transmitted via surfaces or food, aside from aerosol droplets?
You know, in the beginning of the pandemic, we were all really worried about that. And you see this craziness going on with cleaning everything. I think by now it's been pretty well established that the major route of transmission of the virus is through the air, person to person, by droplets, by aerosols, et cetera. That's how it's transmitted. Is there a possibility you could get it from a surface? Sure, probably from like a high touch surface, one that people are touching constantly all the time. But in general, surfaces are really not a major route of transmission. They're exceedingly unusual. They get infected that way. In food, don't worry about food at all. I would completely dismiss food as a level of as a way to get this virus. So that's not even on the table.
Then one last question. From what I hear, there are not different strains of the virus. Why do some get so sick and others are mild?
Well, you know, that's probably one of the $1 million questions with COVID-19 is why some people get mild illness, why other people get severe illness. We know some risk factors. Age is the #1 risk factor for severe illness and death. The older you are, is particularly above the age of 65, they clearly have the highest risk. You know, and then other people with underlying immune problems, people with cardiovascular disease, people with chronic kidney disease, people with diabetes, and people are overweight. Those risk factors we know are definite risk factors for getting severe COVID-19 infection and increased risk for death. You know, but why do some otherwise very healthy young people get it? That's a $1 million question that we're trying to do more research on and trying to figure that out. And if we can figure that out, that would certainly help us better advise people on how to protect themselves and who really needs to be protected. But, you know, we don't know the answer to that question right now.
Okay, we are at the 1:15 closeout mark, and we'd just like to thank everyone for coming again. We will work with our communications team to send out a follow-up to this webinar. And if you have any additional questions, feel free to reach out to myself or Dr. Boer or respond to the email that we send out. So to our panelists, we'd like to thank you for helping to better educate our workforce, and in turn, hopefully that will move into the community and we'll have more folks move toward becoming vaccinated. So thanks again.
Thank you.
My pleasure. Thank you for having me.